Good evening, viewers. We are here with Dr. Abhishek Mukherjee. He is a renowned uro-onco surgeon of West Bengal.
Good evening.
He is here has taken out some spare time from his valuable time which he is in West Bengal, and he is here to answer certain of our common queries regarding cancer, mainly kidney cancer, which is our question today, which we want to find out from him. What are our basic questions which we want to find out from him, right? Sir, if we can start off with the interview.
Yes.
The first thing we would like to know is what causes kidney cancer?
Kidney cancer is very often a random cancer, which means that can occur because of any mutation, and very often we do not find any reason for it. However, among the lifestyle habits which can cause kidney cancer, smoking, cigarette smoking is one of the commonest risk factors for kidney cancer. Which means that kidney cancer can occur in non-smokers too, but occurs more often in smokers. We find kidney cancer principally in a male population who are middle-aged, and most of them are smokers. So one of the basic lifestyle modifications that we advise for patients is to avoid smoking.
Right. So what we learned is that smoking is injurious to health, which we have always known. Next question which I'd like to know is how do we detect kidney cancer?
You see, kidney cancers, like all cancers, initially are very silent and they do not cause any pain or any symptom, and therefore very often we can find the cancers in a late stage. Now, few things like ultrasonography. Now, ultrasound is painless. Now, if a person gets a yearly health checkup, very often it is done nowadays, then the ultrasound can find and catch smaller cancers which have not yet been able to spread, not yet been able to damage the kidney too much. So we do find this incidental cancers. Incidental means that the patient has had no symptom, and yet by chance the ultrasonography could show us the cancer. Now that is a lucky break for the patient, that we find the cancer in an early stage. However, when the cancer reaches a moderate stage, it can start eroding the urinary tract, in which case the patient most often presents with red colored urine, what we call hematuria. Now generally it is a painless hematuria. That would mean there is no pain, but the patient has bleeding in the urine. In a very late stage, we can have development of pain and other symptoms. We always hope the patient does not come to us in the late stage. We would really like every patient to come to us in the early stage, or at least in a moderate stage where we can save a lot of them.
Okay, so if at an early stage or at a middle stage the cancer is detected, then what is the course of treatment that can be the patient can proceed with?
You see, kidney cancers are one of the most treatable cancers, and the bedrock of the treatment is that we rely on removal of the cancer, which is a surgical procedure. Now, if the cancer has involved less than 40% of the kidney, roughly a kidney is about 9 centimeter in the length, and if the cancer is smaller than 4 centimeter, then we try to remove the cancer and at the same time save the rest of the kidney, which is called nephron sparing surgery. Nephron is the basic blood filtration unit of a kidney. Each kidney has about 10 lakhs of nephrons, and we would like to save as many. So we like to give this patient a cancer-free life, at the same time give him as much of surviving kidney as possible. Now that is possible, however, in only early cancers which are smaller than 4 centimeters. However, if a cancer has crossed 4 centimeter in length, which would mean it has already occupied or destroyed a large part of the kidney, in that case the gold standard surgery is called radical nephrectomy, which basically the word radical stands for cancer surgery. Herein what we do, earlier we used to operate by open surgery. That means we cut open the abdomen. Nowadays, as technology has progressed, we try to give a patient the same surgical results, the same cancer freedom, but at the same time reducing the incision. You see, the patient has no disease in the skin or the muscle or the bones. If I can spare the skin, I can spare the muscles, I can spare the bones, then the patient's recovery becomes dramatically better. The trauma reduces. So what I use nowadays is laparoscopic surgery, which means the patient is taken to OT. The patient is under anesthesia. The patient is under deep sleep. He or she has no pain. Now we make 4 small openings, small ports. We call it port. That means each of these are, let us say, if you would try to put a ball pen into the abdomen, then the size of the opening would be less than a centimeter. Now we make 5 such small openings in the abdomen, each opening being smaller than a centimeter. We place our ports through it, we place our camera through it, and we place our instruments through it. Now when the camera is inside, the view of inside the abdomen is then projected onto a large medical grade monitor. So the surgeon is able to see a magnified and hyper clear resolution image. Then, using his hands to control the instruments from outside, I perform the surgery inside the abdomen. Now, as I mentioned, if the tumor is less than 4 centimeter, I would like to remove the cancer. At the same time, save as much kidney as possible. That is called nephron sparing cancer surgery. However, if the kidney has crossed 4 centimeter, then I'll remove the tumor, that is the cancer, along with the kidney and along with its all lymph nodes and fat content around the kidney. That is called radical surgery. Both of these surgeries I perform by laparoscopy. That means making 5 small holes and through which we operate. Now, delivering the tumor. That means once the tumor has been separated from the body, the cancer, we will immediately pack it inside an organ bag. Organ bag is a bag made of plastic. It is a very thick material which does not allow the cancer to spread inside the abdomen. So as soon as the cancer is separated from the body, we pack it inside the abdomen itself into an organ bag. And then we place a small incision in the abdomen, and through which, contained inside the organ bag, we will remove the cancer. Now the benefit of this procedure is that the cancer has been removed by laparoscopy. The trauma to the patient has reduced dramatically. The blood loss is reduced. Patient can be given the same cancer freedom as he or she would achieve in open surgery. We use organ bag so that after the cancer is separated from the patient, it is then confined and arrested within a bag. Now that bag is tough, does not allow cancer cells to leak out, and using that bag we remove from the body. At the end, for removal of this cancer, we place a small incision, generally in the lower part of the abdomen. So the patient does have pain. There is no surgery which is absolutely painless, but the amount of pain reduces dramatically.
Okay, and after this, both the surgeries which you said, both kinds of surgeries depending on the patient's cancer level, what is the survival rate for the patient?
You see, when we find a patient with a less than 4 centimeter cancer, very often we would give the patient an extremely good survival. That would mean that kidney cancers, if they recur generally within the first 3 years of detection. So if a patient has crossed the first 3 years, very often the patient has crossed the bridge and he or she can lead an entirely normal life. For early cancers, the survival can border about more than 90%. Now, when the cancers reach a moderate size, that means let's say more than 4 centimeter, 5-6 centimeters tumor, the survival reduces to 70%. But in late stages, survival becomes much poorer. Therefore, I would, as I mentioned earlier, recommend please do not smoke. Number 2, a yearly ultrasound can often catch cancers in a very early stage, even before they have caused bleeding in the urine. And we would love to have these patients whom we can cure and give a perfectly normal life.
And lastly, what I'd like to know is what is the quality of life that a person can have after the surgery, after both the kind of surgeries?
You see, if we have spared the kidney, that means we have spared, let's say, 60% of the kidney, and the other kidney is entirely normal. In that case, the patient is left with a perfectly normal kidney function. At the same time, if we have ensured a cancer freedom completely, in that case, these patients very often require no radiotherapy, no chemotherapy, and they can resume normal life after 3 weeks of surgery. We will keep them under checkup, obviously, for the next 3 years. But if they cross 3 years, in that case, no further checkup is also required. In more advanced cases, when we have removed the entire cancer-affected kidney, but at the same time preserved the unaffected one, again the patient can return to normal life very soon. However, these are larger cancers and therefore they will require oncomedicine consultation, which would basically mean today these cancers are tackled not only by surgery but also by targeted therapy. In common lay parlance, you can call it chemotherapy, but these are called targeted therapies. We have oncomedicine specialists who will look into the particular case, will try to understand what is the type of this cancer and what kind of therapy will specifically target and help this patient. So these patients generally have a combined approach. One is a surgeon removing the main cancer, and one is after a month a oncomedicine consult, and that oncomedicine consultant will subsequently guide the adjuvant treatment. That means drugs and medicines to prevent or reduce the chance of recurrence of these cancers. Now these patients obviously will have a 3-year follow-up. I would like to mention a test called a PET-CT scan. Now PET-CT scan actually means positron emission tomography. Now this is pure physics, positron emission tomography, but if you understand in layman parlance that glucose is energy. So whenever inside the body a particular area consumes a lot of glucose, it automatically means that area is very alive, very active. Now in our body, normally the brain consumes only glucose. Any place which has a cancer will also consume a lot of glucose, because cancer, as we all know, grows very fast. But also other tissues which are active tissues can also consume glucose. Now if theoretically we can inject glucose into a patient and the glucose molecule is tagged with a chemical which will emit positrons, in which case a particular kind of camera will catch the glow of the positron, in which case wherever this glucose molecule tagged with the positron emitting molecule reaches a particular cancer, the cancer starts glowing. So therefore this is called PET-CT scan. Now in PET-CT scan we can catch hold of not only the primary cancer but also cancer if it has spread to any part of the body. That is called metastasis. So the metastasis, if present during surgery, before surgery, or if they develop later after surgery, they can be caught by PET-CT scan. PET-CT scan is nowadays available in most major centers of India, and therefore we perform PET-CT scan before surgery, and also we perform PET-CT scan 3 times after surgery. The first one being at 6 months after surgery, second at 18 months, and third at 36 months. Now the purpose of this PET-CT scan is to detect spread of cancer. If the cancer hasn't spread earlier before surgery, and if it does not return within 3 years after the surgery, then the patient has sailed through and the patient is a cancer survivor. Lots of patients survive this cancer. Don't get disheartened if somebody near you has been detected with the cancer, but we always like a patient to be able to come to us in an early stage where we can assure a very high survival for these patients.
Thank you, Dr. Mukherjee. On behalf of our viewers, I'd like to thank you because the information which you've shared with us, that is very, very positive. It at least gives us hope that cancer is curable, and therefore we can all look for a better quality of life.
You're most welcome.
Thank you so much.
Thank you. Thank you very much.